I'm Dr. Salil Khandwala, and today we shall be talking about urinary retention. Before we do that, let's just go over the female pelvic anatomy. So this is the head end, this is the foot end, this is the front, and this is the back of the female pelvic area. You have the pubic bone right here, which is this white thing here. Behind that is the urinary bladder, which essentially stores the urine. The urethra is the tube that comes outside from the bladder and delivers the urine to the outside. The vagina lies behind that, and top of that is the uterus and then the rectum behind it. So this is how the female pelvic organs are oriented in the pelvis, and you're looking at this from the side. The kidneys, which are these two organs right here, they filter the blood and then they produce the urine, which is then brought in by these two tubes called the ureters, one on each side, and the tubes open into the bladder and deliver the urine from the kidney into the bladder through these two tiny openings right here called the ureteric orifices. The urine then comes in the bladder, and the bladder fills and fills and fills until it's time to go, like this. All this is controlled by the nervous system. Then there is a sphincter around the urethra which remains tightly closed and opens when it is time to urinate, like now. So that is again under the nervous system control. Retention is when the bladder is not able to do that. That means it is not able to empty itself. And that is where, when we check it out and say, okay, how much did the patient go? Now, frequently it's asked, what is the amount? How much, at what amount would you say that the patient has retention? There is really no finite amount, but typically the amount that is left behind in the bladder after one goes to urinate is about an ounce, 30 ml. If it is usually more than 100 ml, then you start suspecting that maybe the bladder is not emptying well. But again, it could very well be that the bladder may have emptied about 700 cc's. And then if there is 100 left, that's not too bad, So overall, we say that it should be less than about 100 cc's or at least less than a third of the amount put out. So if she puts out, 600 cc's, then it should be typically less than 200 cc's. But usually a ballpark number is about 100 ml. Normally when we are empty, so you may say that, what does that mean? So when I go to the bathroom, is my bladder not completely empty? Well, that's true. It's not completely empty. When you look at this picture right here, there is always some urine left behind there. And, it's just, think about a plastic bag that you just tilt and most of the water comes out, but some water will remain in the creases, and that's what's picked up. So that's about 20 to 30 cc's. What causes retention? So now if it's a true case of retention, what causes it? Sometimes it could just be that when a patient comes to the office, it could just be, she did not really feel like going to the bathroom. She did not have the urge to go to the bathroom, or she just didn't feel like going to a public bathroom. And there are a lot of people who cannot empty. It's usually the bowels, but also cannot empty their bladder in a public bathroom or on command. So it could very well be that. Sometimes it could be excessive fluid intake. So remember, there are two things. When you look at the retention, is it how much is coming in the bladder? So let's look at this picture again, which is this slide. So how much is being dumped in the bladder by these ureters? So are they pouring out a lot of urine into the bladder? Number two, is the bladder able to squeeze and empty itself? And number three, can the urethra relax? So remember, for the urination to happen, we want the bladder to squeeze and the urethra to open. So both this has to happen. So when you look at fluid overload, so let's say someone drinks a lot of fluid, especially what we call the Saturday night effect, drinks a lot more, especially binge alcohol drinking, then the bladder will suddenly fill up, and then because of the alcohol effect, it loses its sensation, and now it becomes too big and they cannot empty. That's not uncommonly seen, in binge alcohol drinking. Sometimes taking a lot of diuretics could have the same effect, where there is a deluge of urine coming into the bladder gets overwhelmed by this lot of fluid coming in, and it cannot respond. The second thing I mentioned about, can the bladder contract properly? So for the bladder to contract, just like what you saw, you have to have a proper nervous system, right? You have to have the nerves which are supplying it, the nerves which are relaxing the muscles. So if there's a neurological damage like a spinal cord compression or spinal cord injury, then there could be a problem with retention. Same thing if there is demyelination, such as with multiple sclerosis, the nerve is not working well, then the bladder may not be able to contract. At the same time, if there has been extensive pelvic surgery around the bladder and the nerves are compromised, especially for cancer cases, then the bladder may not be able to squeeze. There are certain medications called anticholinergics, which are also given for like overactive bladder. And when these are given, then the bladder may not work in some cases. Usually it should still work, but in some cases the bladder may not work and result in retention. Certain infections, such as herpes infection, can act on the bladder nerve and weaken the nerve, and the bladder muscle cannot contract. And that's one of the reasons. The other reason how herpes can cause retention is because of the lesions on the outside. It's very painful to urinate, and that's why the patient is so hesitant to pee, because it'll burn the vaginal skin, and they hold and hold and hold and can go into retention. That's the second. The third part is the urethral obstruction. That means the tube bringing the urine out is obstructed. Now, there could be many reasons. The two common reasons that we see in our field are iatrogenic, that means man-made, and the second is because of a condition called prolapse. So let's see a prolapse. If you look at when there is prolapse, this is the bladder, this is the uterus on the top and the rectum at the back. So this is the front, that's the back, this is the top, and this is the bottom. So when the bladder is falling out, you see how this urethra is bent? Now for the urine to come out of the urethra, it has to climb this, go uphill, come out through this, and come out to the bend, which is very hard to do. So when a bladder is coming out, called a cystocele, like in this case, it's completely out, it's very hard for it to empty, and that's why it keeps filling up and results in retention. The other thing could be if there is a sling procedure, especially the older bladder suspension procedures when they were done. If it is too tight, it'll narrow the urethra, kink it, and the bladder will not be able to empty. So that's a very common problem that we used to encounter with the older sling procedures or the older bladder suspension procedures, that almost every woman initially had to have a catheter. The newer generation slings do not do, because they're more forgiving and they're not that obstructive. And now we have also learned our lessons from the past. The other thing that could obstruct the bladder is if it's a fibroid, as this big fibroid pressing on that bladder and the urethral junction may not allow the bladder to empty. Similarly, in early stages of pregnancy, when the uterus is tilted backwards, so by about the 4th month or so, patients may notice the same effect where the uterus is pressing on this bladder neck, which is the junction of the bladder and the urethra, and that can result in the difficulty emptying. Then there are other cases, such as after a surgery, and that could be because of anesthesia, when again the nerves are blunted and numbed, so the patient may not be able to empty, and the bladder starts filling and filling and filling, and then it's too late once it fills beyond a certain amount. Hemorrhoid surgery because of the discomfort and the pain, same thing with forceps delivery, and any prolapse surgery or anal sphincter surgery. So these are other reasons why the bladder may not empty, and there is something called organ crosstalk. In some patients who have constipation problem, they may also have a nerve dysfunction that could also affect the bladder. So what are the typical complaints of urinary retention? So most patients, they would say that when they go to the bathroom, they're just dribbling. They're not really peeing a whole lot. They don't have a strong stream. They don't feel a lot is coming out. And because of that, they have to keep going again and again and again. And they have this sensation that even when they went to the bathroom, they have not emptied completely, and they feel like I still have to go back again. In some cases, there'll be, because the bladder fills up so much, this is what happens. It fills up, fills up, fills up. There's a big tank that forms, and they'll just push open the urethra, and now they're dribbling. So they're just walking around and leaking urine. So they may call the office and say, I just leak urine. I don't know why it's happening. I'm not coughing or sneezing. I did not have any urgency before that. It just keeps coming out. Anytime I stand up or I'm walking, it's just coming out. And that's the typical dribbling that you may get. The other symptom that you may get, obviously, is because of the stagnant urine. You can get bladder infections and also abdominal discomfort. So the complications, let's say if you left it alone, what could happen from retention? Now, in small retentions where they're not major retention, there may be nothing, and patient may not even realize that she's having it. But patients who are symptomatic and have large amount of urine remaining behind, that could become stagnant and cause bladder infections and kidney damage, as I'll show in a few seconds. So how do you make the diagnosis? We'll talk about each of these at a stage. So first, we have the patients fill up a form, and then they ask, difficulty emptying your bladder, yes, no, and here this would be highlighted. On examination, we would see if the patient has any prolapse or any bulging or anything that could be obstructing the urethra, which could be evident on examination. Sometimes it could also be that the opening of the vagina is narrowed down because of postmenopausal changes, and that could be causing retention. But one of the most important things is to do the bladder scan. So this actually measures, we're putting a probe just above the pubic bone. We measure how much is there in the bladder. And as you can see, this is right in the middle of these two lines. And this tells you it's about 187. So she has some degree of retention. And MRI could also tell you, so this area right here is the bladder. As you can see, it's majorly filled up. This is the pubic bone in the front. The patient is standing. This is the vertebral column. And you can see it's significantly distended. The other way to find out is to put a catheter in the bladder. And by catheterizing the bladder, you will know how much is left behind, and then nothing is left to chance. Once we do the history and the examination, then we have the patients keep avoiding diaries. And by putting a hat under the toilet seat to measure how much comes out, it's how much she puts out, when does she put out, and also how much is she drinking. This is really important. That's why it's called avoiding diarrhea and an intake log. And that is very well explained in one of my separate educational seminars that you should watch on urinary voiding diaries and intake log. So that'll tell us if she's drinking a lot of water, then yeah, the bladder could be overwhelmed, especially if all you see is trickles on this side. The 3-day voiding diarrhea also would help us similarly. And finally, we do this test called urodynamics. I've talked about this also in a separate video educational seminar that I've done. So this basically gives us a graphic representation of the bladder as it is being filled up. So first of all, we make sure the bladder is empty. Then we start filling up, and then we look at what are the sensations. In some patients who have retention because of lack of sensation, they may feel nothing. They won't even feel that the bladder is getting full, and she may have 500, 600, 700 cc's, and there is no sensation at all. Or they may have sensation, but when we ask them to empty their bladder, they are not relaxing the pelvic muscles. And you can see that on something called EMG, where we see the muscles of the pelvic floor and they're firing away. Because it's important that when we urinate, how should you urinate? That's also important to know. So let me tell you that right now. So the way you should urinate is that let it happen. Don't force it. So in other words, sit on the toilet seat and just let the urine come out. When you do that, the urethra relaxes, the muscles relax, and the bladder contracts. No straining. Number 2 way is that the second way of normal voiding, again, when you relax, is where just the urethra relaxes. The bladder doesn't even need to contract because the urethra relaxes so well. The ways you should not be voiding is by pushing, strain down. You do not want to strain, because the more you strain, the bladder says, all right, fine, I won't work. And then it just completely goes by the strain. So that is something you must avoid. And what happens is when people have been straining and straining to pee just because they want to get done and move on, they start compromising the bladder's function. That's important. So the urodynamic testing will tell us the mechanism, how you are urinating, and do you relax the pelvic muscles when doing so. Finally, we'll look inside the bladder. So this is a patient lying down. I've got a telescope inside and I'm looking inside the bladder to see if there's anything called diverticula. You know how they have in the bowel, the sigmoid diverticulosis. This is the bladder diverticula, and that could be holding back urine, or is there anything that it's in the bladder that is preventing it from emptying. Just like what I mentioned, the complications, remember, whenever there is stagnant urine, can lead to infection. Infections could become frequent. That could cause kidney infection, and that can potentially damage the kidneys. Or it can cause stone formation, and bladder loses its tone because it's being stretched and stretched and stretched for so long that it becomes what's called flaccid or atonic. Finally, now you have this constant wetness and dribbling of the urine that is happening all the time, and that becomes a nuisance and causes vulvar irritation, vulvitis, and the vulva becomes extremely chapped. So now that we know what retention is, we know what could be potentially causing it. We talked about the how do we do the workup. Let's talk about how to manage it. So remember this. We have to do something to help the bladder empty, help something for the urethra to relax, and help not too much water come into the bladder. So let's start simple. Simple is behavioral modifications. So that's the first thing. Now, its key thing is you have to watch what you drink. You cannot be like guzzling gallons of water because that will really flood the bladder. Then you must go to the bathroom every 2 hours when awake. So a patient who has retention, we encourage her to go every 2 hours and just go by the clock. 8 o'clock, 10 o'clock, 12 o'clock, 2 o'clock. Just keep going so as to start reprogramming this bladder, which is not working that well. And go to the bathroom even if you do not have urgency or desire to void. Just sit there for a few minutes, relax, don't expect anything, and just get out and come out. But by doing this repeatedly, you are sort of reprogramming the bladder's mechanisms. Double voiding is another good way where you go to the bathroom, you empty your bladder, then you come out fully dressed, you wait 10 minutes, and literally by the clock, you go back in again, wait there for a few minutes, and you'll be surprised that a big urine second stream will come out. This is called double voiding, which is very important. Key thing is please don't strain at voiding. Just let it happen, especially now the problem is the more you strain, it may cause muscle spasm, or especially if there is a sling under the urethra, it could cause a problem too. This is usually done for people who have memory loss and memory impairment called prompted voiding, where a family member will tell her, to go to the bathroom every couple of hours and nudge her, okay, it's time to go, it's time to go. And so by an assistant or a family member or a clock alarm helping the patient to go. Don't forget about avoid this thing, binge drinking, as that can cause a problem. Pelvic floor therapy also is important, and what this does is it stimulates, it sends an electrical stimulation, very mild frequency to the pelvic floor, and it could do one of two things based upon its frequency or hertz. It could help the bladder to contract, or in some cases where the pelvic muscles are not relaxing, we could help the pelvic muscles relax and retrain the pelvic muscles so that if the muscles relax, the urethra, which is the tube that brings the urine down, will relax, and therefore the patient will be able to empty. So therapy could help in more ways than one. As far as the medications go, Flomax, what it does is it relaxes this muscle. So you see this is the urethra, this tube right here has been shown in this picture. So there's a muscle around it, and it relaxes this muscle. And by relaxing that muscle, it opens up the urethra and allows the urine to come out. So it's given a dose of 0.4 or 0.8 milligrams. The reason why you take it at night is because it even relaxes the blood vessels of the legs and lets the blood pool in the legs. So if you stand up suddenly, it can make you feel dizzy. So be careful. Don't stand suddenly after you're on this medication. Go from lying down to sitting, wait, sitting to standing, wait, and then you walk. Now you may have heard of Flomax or tamsulosin as a medication often prescribed to men because for prostate hyperplasia. So it's a very, very common medication given to men, but we also give it to women who have retention. Urocholine is another medication which helps not only relax, but also it makes the bladder contract. Now, sometimes it may make the urethra contract, and that doesn't work well. So that can be given in increasing dosages up to 50 milligrams twice a day. Don't forget that we have to correct the underlying problem. It's not about medications. You must make sure that you drink appropriately. You must make sure that you're going to the bathroom correctly. And then if there is a kink because of the prolapse, you have to get that corrected. If there's any medication that you're taking that could cause retention, then we may have to switch that medication. Most cases are, if they're underlying, they correct immediately once the underlying problem is taken care of. In some cases, we may need temporary management with a catheter, the Foley catheter or a self-catheterization is usually done immediately after an acute event, such as a surgical procedure done that the bladder just needs some rest. You put a catheter in, let the bladder rest, and then it starts working on its own. Or you could do self-catheterization where the patient is taught how to catheterize herself. So she puts a simple catheter, a straight catheter into the bladder, drains it, and takes it out. So it's not staying in there. Permanent catheterization is mainly for patients with MS or neurological impairment. IRSTEM is one technique of helping the bladder also. So it's like a battery stimulation by putting an electrode next to the bladder nerve, and it's got 1, 2, 3, 4 electrode contact points, and then the battery that goes on top of that. Now that procedure IRSTEM is done in an outpatient setting. It takes about half an hour to perform, and the efficacy varies, but at least it's an option available to our patients. Urethrolysis is when a patient has had a previous bladder suspension and it is, there's a lot of scar tissue, then we break it down. If a patient had a sling procedure and it's tight, then I would loosen the sling and that would help. In some cases, I may even have to cut the sling. As I mentioned, straight catheterization is something that may have to be done, and basically the patient is taught how to look at the vaginal opening, how to in a clean manner go into the urethra, how to drain the bladder, and then if it is drained, then how frequently she needs to do it. So she keeps a log of this so we can know exactly how much she is putting out when she catheterizes herself, and eventually we may be able to decrease the frequency to just once or twice a day, or we may not be able to. The most important thing is for the patient to be able to do this on her own, and also to be able to keep a log of how much she's getting out. Patients often ask me that, I put the catheter in and will it cause an infection? Do you know the stagnant urine that is sitting in the bladder is more likely to cause an infection than catheterization? To the point that we tell our patients that you don't really need a sterile catheter. You need a clean catheter. You just have it washed in soap and water, keep it clean, and that is good enough. All in all, it is very important to diagnose this problem. It could be a sleepy problem. It may not manifest itself. Someone may not come and say, you know what, I have retention. Patients may come with frequent bladder infections. They may come with a vaginal bulge, or they may come, with a sensation of urinary leakage. And then when we examine them, we find out, oh, wow, she has significant amount in her bladder, almost 400 cc's. So the key thing is to make the right diagnosis and then come up with the right plan. Most cases of the bladder urinary retention are temporary, but sometimes they can be long-term, especially with neurological conditions such as MS. Key and very, very important thing to note is if it's a correctable problem, such as prolapse, then we need to make sure that's corrected because it'll now prevent you from damaging your kidneys. This is a straightforward problem to fix, and once we fix it, you're able to empty your bladder well. So remember, urinary retention is not uncommon and it should be diagnosed correctly. So if you have symptoms of frequent bladder infections, or you feel that you are not really having a good urine stream and just dribbling out, or you notice a vaginal bulge coming out, well, don't wait too long. Make sure that you get checked out so that we can prevent retention from happening.